Welcome to Podcast UK.
On this episode of Podcast UK, we shall be doing an overview of breast reconstruction after mastectomy.
Hello and welcome to the Next in Our series, starting today with breast reconstruction. And it's my pleasure to introduce Mr Chris Munson. He's a consultant plastic surgeon specialising in breast reconstruction at Leeds General Infirmary. Welcome to the podcast.
Hi Helen, thanks very much.
So today we're going to look at an overview of breast reconstruction, thinking about different types of reconstruction more generally. So to get started, what factors are important for us to consider when we're seeing a patient in clinic who's considering breast reconstruction?
So I think the overriding and most important factor to consider is the patient's motivation. I think it's true to say that not all patients want to have a reconstruction or are appropriate for reconstruction. Unfortunately, the nature of breast cancer is that patients quite often feel that they are on a conveyor belt and that they don't have as much freedom in choice. And so quite often they will turn up to a clinic thinking that they have to do exactly what the surgeon tells them. So one of the important things that I first like to cover with patients is their motivation, their view of their self, their breast identity, and therefore whether they are appropriate for reconstruction. And then we can start delving into the different forms of reconstruction. And if we then are thinking about different forms of reconstruction, then we're starting to think about patients' comorbidities, risk factors such as smoking, their body habitus as well. It's obvious to think of, for instance, a diet patient, that you want somebody with a generous abdomen, but equally I don't want somebody who is morbidly obese because they are likely to have far more problems as well. And then you basically got to sit down and discuss the pros and cons of all the reconstructive options, any adjuvant therapies that they're going to require as well, which is something that we'll come on to a little bit later.
Absolutely. So firstly, would you discuss with patients the option for no surgical reconstruction at all?
Yeah, I think if it's evident that they aren't necessarily interested in a further procedure or an additional procedure with a mastectomy, then we would be looking at the non-reconstructive options. And there are good options for patients. The breast prostheses are very, very good. They're sized very carefully for those, and you can achieve very good symmetry. It comes with the downside of obviously having to carry a prosthesis around with them. It limits on things like swimming and swimwear and lower cut tops and things like that. Alternatively, a lot of women are very happy with a simple mastectomy. And I have met plenty of patients who have embraced the fact that they've had a simple mastectomy and will elaborate on that with things like tattoos around their scars and such like.
Thank you. So moving on from prostheses and mastectomy options, could you now give us an overview of implant-based reconstruction options that are available?
Absolutely. Implant-based reconstruction has been the mainstay and remains the mainstay of breast reconstruction in this country and most of the way around the world. It is a very good reconstruction for a lot of people. It's not right for everyone. The implants fall into one of two categories, basically. There's either expander type implants that go in slightly flatter and allow you to expand over time. And these are a good option when you are limited in space, perhaps a patient that you are seeing for a delayed reconstruction who've had a previous simple mastectomy. Or you have definitive implants that are at their final volume. When assessing a patient for an implant, I will be considering a number of things with them really, and we'll talk about the advantages and disadvantages of it. For those that it's appropriate in, the advantages are that it's a shorter operation. It certainly has a shorter recovery period than many of the autologous options. It allows fairly accurate matching to the contralateral side. Alternatively, in bilateral surgery, you can put the same size implant in both sides and know you're getting the same size. The disadvantages are that it isn't right for everybody. We tend to try and avoid it in patients who we know are undergoing radiotherapy or have had radiotherapy previously. Certainly patients who smoke, it is not a good idea. It has a very high risk of wound breakdown and implant loss. And the other fact is it's a foreign body that's going into the body. It will need revision at some point in the patient's life. And as such, it can be treated as a foreign body by the patient, effectively can be rejected. You can get things like capsular contracture, which we'll talk about. So it isn't necessarily the right option for everyone. In the last 10 to 15 years, we're seeing increased use of mesh and ADM, or acellular dermal matrix, as well with implants. It offers some advantages. I like using ADMs. I have plenty of colleagues who like using meshes. The place where I primarily use them is for pre-pectoral reconstructions, where you're trying to control the pocket. And for the vast majority of the time, the mastectomy pocket that is created is larger than the implant. And so if you don't control that pocket carefully, then you'll have an implant that disappears into the axilla or descends onto the upper abdomen. So what I primarily use the ADMs for is controlling the pocket that the implant is sat in. The other advantages of ADMs are in patients who are particularly thin skinned. It adds an extra 2 to 3 millimeters of thickness in front of the implant and allows you the option in the future of being able to lipofill and fat graft into that plane.
Fantastic, thank you. So you mentioned the pre-pectoral pocket there. Could you just please elaborate a little on what factors affect your decision as to where you place your implants?
Absolutely. Implant placement in reconstruction has gone through a little bit of a life cycle. So originally, patients would have effectively a subcutaneous mastectomy, and the implant would be placed in that subcutaneous plane, effectively pre-pectoral before we called it pre-pectoral. The trouble with that is wounds would often break down, implants would become infected, and you had fairly high levels of implant visibility, rippling and capsular contracture. So then things moved into a submuscular plane, and it's important to differentiate it between submuscular and subpectoral. So submuscular plane would be underneath the pec major, but also under serratus muscle and upper rectus abdominis. The trouble with that is it's a tight space, and so therefore that's where expanders were quite often used in order to stretch that space up. Things then progressed a little bit more, and we moved into the subpectoral plane, and implants would be covered superiorly in that subpectoral plane, and then inferiorly would either be left with no coverage at all, or that's where early use of meshes and ADMs came in to provide a little bit of a hammock and a pocket at the bottom of the breast there. And then within probably the last 10 to 15 years has seen more of a rise in the use of the pre-pectoral pocket again. And the reason that has risen again in popularity is for several reasons. First, anatomically, it's the correct position for a reconstructed breast to sit. The breast sits in front of a muscle, it doesn't sit underneath the muscle. The other reason it's raised in popularity is it bypasses some of the disadvantages of subpectoral implant. It is a less painful operation. Sticking things underneath the pec requires a fair degree of stretching, even if you're using a definitive implant. You also can have problems with something called animation deformity, where the insertion of the sternal head of the pectoralis major muscle acts as a fulcrum, and whenever the patient activates their pectoral muscle, it causes a kind of a dancing effect or animation effect of the breast. So by going in the prepectoral plane, we bypass that, and you don't get an animation deformity if you move in that plane. That combined with better quality implants, better quality ADMs and meshes, and better general implant hygiene. So the way that we manage the operating theatre and putting those implants in means that we're achieving far better results in the prepectoral plane. It is true to say that it does have its disadvantages, and those mostly come in the form of visibility and rippling of the implant, but to a certain extent some of that can be bypassed with the use of fat grafting.
Great, okay, thank you. So shall we move on now to look at autologous reconstruction options? Could you first give us an overview of the different autologous options that are available for our patients?
Absolutely. And we can think of this almost a little bit of moving up through the reconstructive ladder or elevator. First, autologous reconstruction options are going to be local options. So there's local flaps that can be used for partial breast reconstruction or a whole breast in patients that are smaller breasted. And they fall in the categories of chest wall perforator flaps. For the most part, they're based on intercostal perforators, both inferiorly and laterally in the breast. And then we can move on to kind of regional options. And I would class things like a thoracodorsal perforator flap within there, but also the more traditional autologous regional option, which is latissimus dorsi flap. The advantage of a latissimus dorsi is it brings a skin paddle with it. So if we're looking to replace any skin even taken out at the time of an immediate reconstruction or in the delayed setting, then we can bring that skin in. It often is combined with the use of either an expander or an implant. We then can go to more distant options and free flap options. Undoubtedly, the most common is its current iteration being a DEP or deep inferior epigastric perforator flap. Previous iteration of this was a tram flap, so transverse rectus abdominis musculocutaneous flap. These are absolutely the workhorse flaps for breast reconstruction, and of my free flaps, they will take up probably 90 to 95% of the free flaps that I do. Some patients are inappropriate for a DEP for whatever reason, be it that they've had extensive abdominal surgery in the past, or they just don't have adequate tissue, or through patient choice, they would rather not have their abdomen used. And then we look elsewhere. My personal second flap of choice is tub flap, so a transverse upper gracilis flap. Other possibilities are things like a PAP flap, so a profunda artery perforator flap, which comes from the same inner thigh area. It's just centered slightly more posteriorly than a tug. And then there are still some people that are using superior gluteal artery perforator flaps or inferior gluteal artery flaps. They're by and large fallen out of favour because they are relatively tricky dissections through muscle, and they end up with a fairly short pedicle that goes with it. So quite often you need to augment that with a vein graft.
Thank you. So you've touched on this a little bit already in the discussion previously, but could you elaborate on the pros and cons of immediate versus a delayed reconstruction?
Yeah. I think we still, by and large, think of the gold standard being an immediate reconstruction. But again, it's true to say it's not right for everybody. Obviously, the advantage of an immediate reconstruction is it's effectively one procedure that the patient is having. They go through that all on the same day. They go through their recovery period in the same space. And if recovery goes well, it means that they can get on with any adjuvant therapies fairly soon afterwards. My personal view on radiotherapy with DEP flaps is that I'm perfectly happy for my flaps to undergo radiotherapy, except the fact that they will have a little bit of shrinkage to them. Sometimes you can have some problems with wound healing. But I think in a patient who you know is going to have radiotherapy, it really is the reconstruction of choice.
The real problem with immediate reconstruction in the context of a patient with breast cancer is if there are problems with either the free flap itself or the donor site, then this can delay any adjuvant treatment in the form of chemotherapy or radiotherapy. The other thing that I've heard from my own patients is consideration of the enormity of the operation adding another factor into their decision making. And there are a fair few patients of mine who have felt that actually going ahead and having immediate reconstruction at the same time is a little bit too much for them to contemplate and to go through. And so they will elect to have a reconstruction in a delayed setting.
It is true to say that the coverage of free flap reconstruction around the country does not accurately match those of all the breast units in the country. And so therefore getting access to an immediate reconstruction can be more difficult. And it is also a much bigger operation than a simple mastectomy. And so the patient has to be on board for that reconstructive journey as well. Whereas if we looked in the delayed scenario, certainly the advantages to that is that for the most part, patients can be through their adjuvant treatments and effectively be in remission from that. So that effectively the life-saving surgery has been done for them. The other advantages that I find personally is that actually have a little bit more control over the shape that I can achieve with the reconstructed breast afterwards. With the delayed, quite often you are replacing a skin paddle at the bottom, and I find that I can quite accurately control the shape of the breast afterwards with that degree of control that sometimes you don't have in an immediate scenario.
May I just interrupt there?
Yeah, of course.
So what makes the difference there?
So effectively went a little bit like we talked about with the implant-based reconstruction. When you've had a mastectomy, the mastectomy pocket is often quite large, unnecessarily so. Whilst as plastic surgeons, we would love all of our breast surgery colleagues to stick rigidly to the anatomical footprint of the breast. Actually, we have to remember that sometimes you will necessarily creep outside that to try and ensure that you've got all the breast tissue out that you can. That combined with the fact that sometimes patients have a far larger breast pocket than the flap that you can necessarily put in there. It means that you are sometimes having to tailor the size of that immediate breast pocket in order to suit your flap. Throw into that as well, if you are doing bilateral surgery, whether you are symmetrizing them at the same time or not as well. So I generally find that, particularly in patients where you're looking to adjust the size of the contralateral side as well, that actually the delayed setting, I just find that I have a little bit more control. There are less moving parts involved in a delayed as well. We're not having to coordinate several teams. We are therefore a little bit less subject to last minute problems, hiccups, cancellations and such like. The big disadvantage of a delayed reconstruction is that it is delaying and it's prolonging that period for a patient. You could argue that another downside is that you're left with a larger skin paddle with a delayed reconstruction. Generally speaking, most of my patients don't complain of that. Interestingly, when you look at the PROMS data on this, generally speaking, autologous reconstruction patients are the happiest. However, delayed patients tend to be a little bit happier than immediate patients. And I think that's a little bit of a skew in the data, in so much as because the delayed patients have been without a breast, they actually are more appreciative.
Yes, I was going to ask if you'd found a difference in how patients felt after a period with a mastectomy.
And I think that's true. I think the immediate patients go to sleep with a breast and wake up with a reconstructed breast. And so therefore will make immediate comparisons to the breast that they've lost.
Exactly, yeah.
Whereas a delayed patient will go into theatre with nothing and come back with a reconstruction of some form.
Mm-hmm.
So again, I think we've touched on this earlier in our discussion, but since DIEPs are really the mainstay of autologous breast reconstruction in the UK, I think it's worth getting a little more detail here. Are there any particular factors that would definitely steer you away from a DIEP or a TRAM reconstruction?
Yeah, and as you quite rightly say, we've touched on some of these already. I would come back to the first and most important thing being patient motivation and ensuring that they are on board with this as a reconstruction for them and that they understand the risks and complications associated with it, the recovery period that's associated with it. Then, more practically, do they have an adequate abdomen for it? Now, quite often you'll see patients who don't look like they've got very much adipose tissue on their tummy. Actually, most people have got more than you think. And there are little tips and tricks that you can do to extend the volume of fat that you can get in there. You can do a subscarpal extension superiorly. You can always do a little bit inferiorly as well. You can buy pedicle flaps, so either stack them or do them as two separate flaps in order to maximize the volume that you can get from there. Other things that I'm looking at is a history of abdominal surgery. Now, I remember when I was coming up through training, anybody who even had a cesarean section we used to say no to, but that's very, very different now. I've done reconstructions for patients who have had midline laparotomies. We get a CT scan or an MRA in other places to assess for the vessels in the first instance, so we know what we're going into. But if the vessels are there, they're there. It doesn't matter they've got a midline laparotomy scar, you just don't include that in the reconstruction. And I've had several patients that have performed bilateral reconstructions who've had midline laparotomies, and not only are they grateful for their reconstruction, but they're also grateful for the fact that we've effectively reconstructed their abdomen as well. Big no-nos as far as I'm concerned is smoking. Interestingly, most of the data says that the problem is not with the anastomosis itself, with smoking. It tends to be more to do with wound healing. However, I'm not that keen on putting a patient who's an active smoker through such a long procedure anyway. I personally have a cut-off BMI of 30 for my DIEP reconstructions. And again, that is less to do with the survivability of the flap, although there is some association with increased flap failure with higher BMIs. It is more to do with wound healing. And on the occasions that I've pushed things, and I've accepted patients who are 32, 33 BMI, months, and I mean months later, you are still having problems with wound healing, either on the breast or more likely on the abdomen. So they're the particular areas that I would be steering away from. And then again, we come back to patient choice. I do have some patients who have got perfectly adequate abdomens who say, look, I don't want you to touch my abdomen. I'd like to go from somewhere else.
Yes, absolutely. Again, we've touched on this earlier as well, But does the type of surgery you offer, or the timing of the surgery, depend on if the patient is going to have radiotherapy in the future?
Absolutely. And we talked about the relationship of radiotherapy and implant-based surgery. The general accepted understanding is if you know that you're going to have a patient who's undergoing radiotherapy, you should steer clear of implants. I would qualify that slightly. And what we are finding with some of the data that's coming out with particularly the use of ADMs is that the capsular contracture rates associated with implants that have been irradiated are slightly lower than accepted. And in fact, I have a bit of a tertiary referral service now for patients who have had radiotherapy in the past, have had a capsular contracture, and I'm going back in, performing capsulectomy, exchanging their implant and using an ADM and some fat grafting over the top of it, and they don't get repeat capsular contractures. When it comes to question of radiotherapy and DIEP flap or other free tissue, it really is a bit of an area of controversy throughout the country and throughout the world. There are some units and some surgeons who will say, absolutely no, you're not going to irradiate my free flap. I have to say I fit in the category of saying I think it is the reconstruction for people who are going to have radiotherapy. They are pretty hardy against radiotherapy free flaps. We know from head and neck cancers that actually they do stand up to radiotherapy pretty well.
And has timing got anything to do with that?
Yeah, our oncology colleagues will want to get on with radiotherapy as soon as they possibly can after surgery. So they need wounds that have healed. So therefore, some would argue that a simple mastectomy is your quickest route to healing and allowing to get on with radiotherapy. I think in high volume units who are doing lots of DIEPs, actually we get them healed pretty quickly. Most of my patients will come back first week post-operatively and are well on their way to healing, and 2 weeks post-op they're healed. So would be able to start radiotherapy.
Excellent. Okay, so finally, a question about your own experience. Looking for secrets of success, do you have any top tips or things that you've found as a consultant have helped you in your practice that you've picked up over the years that we don't always find in the books?
Yeah, and I think the thing to remember with the books in inverted commas is they tend to run quite historically in nature. They can't keep up with modern thinking and modern practice. I have to say I was extraordinarily lucky in that I completed an oncoplastic TIG fellowship in Manchester for a year and then followed that on with a high volume microsurgical reconstruction service again in Manchester, and learnt so much from that fellowship that I've taken forward into my consultant practice. I would say top tips are fellowships. I think if you're looking to provide a far more holistic approach to breast reconstruction, then oncoplastic fellowships are not a bad idea at all. And certainly a lot of the skills that I employ now come from the oncoplastic side of stuff as well. I think fellowships are a great idea purely for high volume operating. It's just doing the same thing over and over again, and you will naturally therefore encounter common problems and difficulties that you will learn your way around. You will also naturally become more efficient and more effective the more operating that you do. That clearly isn't the focus earlier in training. That's certainly a fellowship thing. I think my biggest tips actually come away from the operating theatre altogether. And what we have managed to achieve in Leeds now is our average length of stay is 2 days after a DIEP. And the reason for that has an awful lot to do with education. Education of patients so that they know what to expect, what's coming up, what's going to happen in the post-operative period, but also education of ward staff, of our physiotherapy staff. We get our patients up and going the day after surgery. In fact, quite often they are sitting out the night of their DIEP. We avoid using things that, generally speaking, tend to slow patients down. So I don't use any kind of PCAS system. I avoid drains as much as I possibly can. I don't use any drains in the abdomen. I only use drains in the breast for immediate mastectomies, certainly not for delayed, and even for risk reducers, I don't use drains anymore. So the fewer things coming out of the patient, the more likely they are to get up and going. Catheter comes out night of, if not morning after, if they're struggling a little bit. IV fluids stop the night after their operation, and so that the morning after their procedure, they are ready to get up and start shuffling to a commode, to the toilet and such like, and that gets them going. And our physiotherapy team are very much on board with that. We give our patients an extensive education on exercises to do at home and an appreciation of what's too much to do and what's too little to do. And then we see them back soon. We see them back in a week and make sure that everything's going well from that perspective.
The team around the patient is so important in these operations.
Absolutely.
When you talk about sort of patient education, obviously discussing all of these aspects at length in the clinic setting, is there anything particular that you found gives people the knowledge and the motivation that they need?
So we're lucky in Leeds in that our breast care nurses are very proactive with this thing. They're very on board with autologous reconstruction. So they run seminars for patients, particularly in the delayed setting, because obviously there's a little bit more time for things like that. But even from first consultation and diagnosis of cancers, they are very much aware of autologous reconstruction being an option for them and are discussing it with patients. When I see patients in clinic, I have a set slideshow that I run through with them that involves explaining how the operation is done, as well as some both cartoon type pictures and also patient before and after photographs that I can run through to show them so they know what to expect. And one of my former trainers would always say, under promise and over deliver with these things. Prepare patients for all of the worst. And actually, the vast majority of them, that's not going to affect them and they're going to have a great outcome. What I would say, the most important thing actually is communication with the patients through the whole journey. I'm very lucky in Leeds in that I have a fellow who will go and see the patient every day and check on the flap and such like. And so that when I go and see the patient, I don't really even need to go and look at the flap. I'm just there to have a chat with the patient and make sure that they're happy and on board with everything that's going on. And they then feel that they're getting kind of special treatment, but it's the same that I give to all my patients. And that is very, very true when you have complications. Patients very rarely will complain because something's gone wrong with their surgery. They will complain if they have felt that they've had poor communication and they didn't know what's going on. So in the rare instances that I have problems with free flaps, I am informing the patient all the way along, this is what's happening, this is what we're going to do, I will update you as we go along. And the very few patients that I've had flap failures in, they are not upset because they have had a flap failure. They are understanding of it, and we've found alternative reconstructions for them that they've been very happy with.
That follows nicely to, those cases, unfortunately, where the reconstruction fails.
Yeah.
How do you deal with that?
I have to say, I personally really struggle when we have problems with flaps because I take it very, very personally. And I think that's not unique to me. I think that most reconstructive surgeons struggle when they have flaps that fail. I reiterate communication with the patient. Communication with your whole team is important along the way. I think it's important to look at each case and analyse, see if you can work out what went wrong in each instance. We are in a very lucky period of microsurgery now when anastomosis failures are very, very rare. In a way, the nice thing about anastomosis failure is you can do something about it. You can take it back to theatre and redo it. The flaps that I've had fail, I don't think any of them have been an anastomosis failure. They've been an intra-flap failure where there just has been an insufficiency within the flap itself. And despite additional anastomosis, vein grafts, so on and so forth, the flap just does not want to work. And that opens up a whole other kettle of fish on how you manage an intra-flap failure. I very much follow the advice of very learned colleagues who have pointed out that an intra-flap failure is almost certainly due to endothelial damage further down the arterial tree or vascular tree. And although we can flush out a flap with alteplase, streptokinase, whatever you want, any form of clot buster, actually it doesn't fix the underlying problem, which is endothelial damage. So you will soon clot that flap back off again. And whilst you may get the flap working again for a short period of time, it will ultimately fail. which is all very depressing. But I think the important thing is never be without backup plans. And I will very, 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 very rarely do an operation where I don't have a lifeboat or a backup plan. For things like DIEP flaps and tram flaps, you have the options of other free tissue transfers, although relatively recently there's been some good papers that have shown that flap failures are fairly high in reflap procedures. My personal backup choice quite a lot of the time will be some form of implant-based reconstruction, possibly with the use of an LD as well, and utilising all those skills of using ADMs and lipofilling and such like as well. To the extent that particularly in immediate reconstructions and risk-reducing reconstructions where you have an intact breast pocket, included in my consent will be the use of a salvage implant for those patients.
Just go back to me about endothelial damage. Is that just damage that happens to be in the tissues of that patient, or is that do we
probably
know?
The truth is we probably don't know, and it's relatively difficult to predict those patients.
It's interesting that you say if a patient has one flap failure due to endothelial damage, then further attempts at a free flap may follow suit, even if it's from a completely different area.
Yeah. There's a fairly recent paper in, I believe it's in JPRAS, that was talking that second flap failure rates sat somewhere between 40 to 60%, which is enormous. And that is using a different recipient vessel as well. So in the example of breast, you may have used internal mammary vessels, you switch to thoracodorsal vessels for an alternative flap and it still fails, which suggests that there is something inherent in that patient, which means that they will struggle with an autologous reconstruction for some reason.
Fantastic. So I think we've covered a lot of different areas today and given a very clear overview of the different types of breast reconstruction available. I hope you've all enjoyed listening, and thank you very much to Mr. Munson for your expertise today.
Thank you, Helen. It's been a pleasure and an honour to be invited onto Podplast UK. I've enjoyed it very much.
Goodbye from Podplast UK.
Podplast UK is a collaboration between UK and Irish plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.